These are my disclosures. In life and HIV, unfortunately, women often bear a heavier load. And women living with HIV experience much more depression, anxiety, post-traumatic stress, and even anti and postnatal depression than men living with HIV and women without HIV. Women are also most likely to demonstrate progression of depression over time compared to men living with HIV who seem to have a much more stable depression over time. In heterosexual relationships where at least one of the persons in the relationship is HIV positive, women, again, regardless of HIV status, report high psychosocial distress, obsessive compulsiveness, interpersonal sensitivity, etc., than their male partners. Loneliness appears to be present in similar proportions of men and women, at least as far as we know so far. But during COVID, women living with HIV reported a much higher burden of COVID-19 on their daily lives, as well as experiencing higher levels of stress and loneliness. Women are not all equal in their experiences. Other factors seem to contribute to worsening of mental health and loneliness experiences. So, for example, Black Americans and Black Brits more frequently report higher levels of depression compared to their white counterparts. At least for the study that looked at in the UK, the Black Brits were more likely to be university educated, but were less likely to be employed and less likely to be making a living wage. Black Brits were also much less likely to actually have a depression diagnosis. And the authors of that study hypothesized that it potentially could represent some differences in health equity and access. Nearly half of trans women report clinically significant PTSD, as well as depressive symptoms, and routinely report suicidal ideation. And women living with HIV and injection drug use also seem to be particularly vulnerable to mental illness. They are the most likely to report depressive symptoms in a group of men, women living with and without HIV and injection drug use. And one of the reasons why we see such variability is because of the intersectional experience of women living with HIV. So we're all different. There are multiple different factors at the individual level or the intrapersonal level, interpersonal level, and structural or society level that impact our experiences. At the individual level, gender, race, ethnicity, whether or not you're using substances, all of those things could more negatively impact your adversity, to your life adversities. At the interpersonal level, negative stereotypes could impact you or not. And then at the structural level, there could be discriminatory policies in either the state or country that you live on that could more negatively impact you than a woman living with HIV somewhere else. This study looks at the impact of HIV on women. This is just looking at some of the mental health symptoms and syndromes. So they asked a whole bunch of women from across the globe to say, did you have this condition before your HIV diagnosis? Did you have it after? And then they looked at how much more women experience things like depression and shame after their HIV diagnosis. And if you look here, this is kind of like the money column is this extent of increased fold here right in the middle, where you just see anywhere between, like 1-fold harmful use of drugs, alcohol. Okay, that's not bad. Up to 6.7-fold more paranoia. So lots more depression, lots more anxiety, a lot more suicidal feelings. Clearly the HIV diagnosis is impacting women in a major way. This quantitative data was nicely complemented with some qualitative data where women shared why they thought their HIV was impacting them and what factors they thought were contributing to this higher fold increase in a lot of these mental health conditions. HIV stigma was a big factor. A lot of them talked about, having to hide their HIV, being discriminated against, rejection, social exclusion. Many had sleep problems related to their HIV following the diagnosis, related mostly to stress and trauma. Other intersectional stigmas came into play. Mental health issues and stigma and substance use all kind of came together to really impact their sexual and reproductive health, as well as their sexual risks, and as well as reporting some reproductive health barriers and human rights violations that occurred after their HIV diagnosis. And what I love about this study is that it's already so beautifully complemented by work that's been done in women living with HIV that definitely confirms that all of those factors that the women identified as being a major barrier or issue with living with HIV have already been confirmed. So we already know, like that HIV stigma really impacts mental health in women, intimate partner violence, cumulative lifetime trauma, all of these things contribute to the mental health of women living with HIV. And then substance use. As I was thinking about how do we put together all of these different factors, there's a lot going on here. The reason we want to kind of conceptualize and think about where do things fit, what causes what mediates different types of outcomes, is because it will help us identify like what's the low-hanging fruit, where should we be intervening in to really help women manage their mental health and loneliness better. So this study was done on a Canadian cohort and really evaluated and identified that multiple stigmas, or the intersectional stigmas of HIV, race, and gender, contribute to, through violence, significant depression in women living with HIV. Another study, totally separate cohort in the US, so can't use the numbers. I'm just doing this to kind of try to put the whole picture together, looked at the relationship between stigma, depression, and substance use. And here they found that certainly stigma does, contributes to some of the substance use that they were seeing, but it really seemed to be the depression that was highly mediating substance use, whether or not it was how much of it was used and the types of substances that were used. Loneliness. So there's another study that actually looked at the relationship between stigma, loneliness, and depression. This was not only in women. So I put it here. We don't know yet if this is exactly where it belongs, but they identified that loneliness was a mediator between stigma and depression. And of course, all of this is happening within the context of economic insecurity of women living with HIV. So lots of potential things that we can identify here that we can target that might mediate or improve the mental health of women living with HIV over time. Depression, substance use. I suspect substance use also, it's probably more of a cycle rather than just unidirectionally from depression, violence, and loneliness. So untreated mental health, I think most of us know, or are at least familiar, that untreated mental health impacts HIV risk factors, as well as HIV outcomes. So if you look at the graphs here, this is a classic graph that, it basically is the risk ratio versus the percent of days of depression or depressive symptoms in women living with HIV. And we see that as depression goes untreated over time, women living with HIV are more likely to miss HIV appointments. They're less likely to have 95% antiretroviral therapy adherence, and they're more likely to experience virologic failure. But what's more worrisome is, apart from those HIV outcomes, women with chronic depressive symptoms are 2 times more likely to die, at least in the US. And in a similar study in Tanzania, an estimated 36% of deaths in this longitudinal study cohort that has been evaluated was attributed to depression and its consequences. So untreated mental health is deadly, not just because of its impact on HIV outcomes, but because of other factors. And it goes beyond HIV outcomes. So women living with HIV with high psychosocial risk, which was defined as kind of a composite score of depression, stress, and PTSD symptoms, they were more likely to have carotid plaque than women that did not have those same types of symptoms. High depressive symptoms reported more than 45% of study visits was associated with new plaque formation, also at a much higher rate, 17% compared to 9%. So mental health, psychosocial factors, loneliness, seem to also impact cardiovascular risk for women living with HIV. We don't have similar data for loneliness. And I put up this loneliness slide here more to kind of just get us all thinking about it. I think the work with loneliness is still early, particularly with women living with HIV. We don't have a lot of data on it yet, but there is some suggestion that loneliness can contribute to other important outcomes, particularly as people living with HIV are aging, substance use, lower mood, cognitive impairment, and physical inactivity. These will negatively impact people living with HIV as they age. And if indeed loneliness is contributing to the development and persistence of some of those conditions, it is another condition that we need to be aware of and be treating and managing. And the biology supports it. So some of you might be like, oh, why? Why does depression cause, increased risk of cardiovascular disease, and how could loneliness possibly contribute to things like, I don't know, cognitive dysfunction? There is actually data to support why. We do have reasons why we think that this is happening. So stress, which often accompanies things like depression and loneliness, activates the hypothalamic pituitary adrenocortical axis, which pumps out cortisol, as well as the sympathetic nervous system. And together, that results in someone experiencing kind of this chronic state of fight or flight. And that results in multiple changes in blood vessels, vasoconstriction, as well as several other factors that predisposes to early or premature atherosclerosis. Stress also alters gene expression. So there is a block of genes called the conserved transcriptional response adversity, or CTRA. You'll probably see that thrown around a little bit more easily, that is affected by all stress. So loneliness, social isolation, PTSD, racism, acts of discrimination, all of these things have previously been demonstrated to alter the gene expression of the CTRA so that it results in a pro-inflammatory milieu. Subsequently, or complementing the stress-activated HPA and sympathetic nervous system activation together to further enhance atherosclerosis. So in summary, mental health and loneliness are very common, and they negatively impact women living with HIV. So let's do something about it. One low-hanging fruit that I think we could be able to implement sooner than later is really to encourage our women and us to get moving. There's early but very promising data that exercise can be a great moderator of mental health and loneliness. So women living with HIV participating in an exercise training program 3 times a week for 12 weeks demonstrated decreased somatic symptoms. They had much less anxiety and less severe depression. They also had some improved social functioning, and their CD4 T cells went up. Women who participated in 6 weeks of prescribed exercise, this was basically, they were given a book, like an exercise book with instructions, and then they also had to log in when they were exercising. So there was kind of a bit of accountability to it as well. They also experienced decreased depression. They also had some improved body image. That study was done in sub-Saharan Africa. The other thing I think that I thought was really cool was, lay health worker-led physical activity counseling and exercise. This program was once a week for 8 weeks. They saw small reductions in HIV-related stress and global disability, but they saw very large reductions in the time that women living with HIV spent sedentary, and large reductions in depressive and anxiety symptoms. And this was done in Uganda. One thing that could help you today is potentially start providing exercise prescriptions. So Jessica Montoya and Christine Erlandson created this exercise prescription. They wrote a paper back in 2019. It's referenced down there. And if you are interested in encouraging your women to get up and get exercising, sometimes it's a little bit more helpful to give them a prescription rather than just encourage them or counsel them to exercise. It's something that's it's physical. You're giving it to them. You're telling them exactly what you want them to do, and you are going to follow up on them. So I'd encourage any of you who are interested to try that and see how it works for some of your women living with HIV. But we also need to be fostering biopsychosocial resilience. And I don't have time, unfortunately, to go over this slide. I think this is maybe mostly known to people, but there's 4 things that I think we really need to be doing. So we need to normalize. We need to normalize mental health. We need to normalize taking medications for it. And we need to normalize behavior therapy and needing human connection. We need to engage more help. We need to implement a lot more of these therapies, including treatment of mediators, and advocate. Supportive services are essential services. We need expanded services, and we need community capacity building, especially around interpersonal violence. Of course, all within the context of inclusion health. And these are my acknowledgements. I'm so thankful for the women living with HIV that share their stories and experiences with me, as well as my mentors and colleagues and my research vendors. Thank you.